Yeah.
Yes. Yeah. Good evening to all. Sincere thanks to this academic committee of the Spine Committee and Middle Spine and WFN Spine Committee.
You can put total screen, please.
This is fine.
No. Yeah.
You can now. Yeah. So coming to the introduction, actually, the neurosurgery spinal cord tumors, its goal is to achieve the safe maximal resection with the oncology and functional balance. Though recent advancement very good in neurosurgery, but still it bears a significant risk in removing these spinal cord tumors with a mortality range of 3.7 to 7.5%. The IONM tool, which represents the mapping and monitoring of the spinal cord and nerves in a real-time manner during the surgery. In this evidence-based era, still you need to demonstrate the effective role of IONM in spinal cord tumors. That means that choosing the right IONM techniques that gives a appropriate silence during surgery is more important. When it comes to the spinal cord tumor surgery with IONM, so single IONM technique is not that much useful to manage to preserve all the neural functions. So therefore, it requires some multimodal techniques in especially the extradural or intradural, intramedullary, and also conus mass. Coming to the location of the tumors, the cervical is more risk than the thoracic and the lumbar. Coming to the way, the surgery with the IONM is really a challenging, but elevating the surgical skills and preserving the real functions. Therefore, the IONM gives that margin for error, which is very small during the course of surgery. However, when it comes to the conus and cara icona, is that another distinct, actually. And the spinal cord tumors, which is operated since in the 1907 by the group of people in Vienna without IONM. When it comes to the IONM, they introduced with the spinal cord intramedullary tumors, which is started in 1975. How it's performed with the IONM is actually stimulating the motor cortex and the electrical stimulus, which goes through the cerebral peduncle and pyramidal tract and elicit the compound muscle action potentials from the distal musculature. There is motor-pathway, which is MEPs. Coming to the SSCPs, actually, you can stimulate the peripheral median nerve or posterior tibial nerve for the lower limb, and it goes to the dorsal median lemniscus system and recording the response from the postcentral caudus, which is the SSCPs. Coming to the multimodal IONM techniques, in spinal cord tumors are somatosensory evok potentials, motor potentials, D-wave monitoring, nerve monitoring, mapping and monitoring with the electromyography and also the reflex monitoring. Coming to the SSCPs that can be used to monitor the dorsal column median lemniscus pathway. These dorsal columns are highly vascularized by the pad of posterior spinal arteries. Therefore, the SSCP can help to monitor the functionality of the neural circuits during the course of spinal cord tumors removal side. SSCPs can be done in a two-way. For the upper limb, one is the median nerve, which we are stimulating the brief electrical shock on the median nerve on the bilaterally and trying to record the response from that C3- and C4- in the cortex according to the 1020 EEG system. Coming to the posterior tibia now for the lower limb, actually we are stimulating the posterior tibia now in the ankle, and the stimulus goes all along the through the spinal cord, and we are recording from the CZ, which is the CZ-, which is the according to the 1020 EEG system in the cortex. This is a typical illustrative example picture of that actually the median now for the upper limb, and this is a picture for the lower limb, which is for the posterior tibia now. The stimulate parameters are actually the ratio of the SSCP is to stimulate and identify the vascular injury to the nervous system during the surgery, as well as to monitor the sensory functions. We'll use the bipolar stimulator, which is a strip or bar electrode, and the contralateral median or bilateral median now, and the posterior tibia now. The frequency rate is 4.1 or 4.7 with the stimulus ranges from 15 to 45 milliamp current. The recording parameters are actually cosmos, electrodes, or disc electrodes. You can place the C3- or C4- on CZ- for the lower limb. The SSCPs are highly useful to identify the safe entry zone, which is for making the myelotomy, especially in the tumors, intramedullary tumors. when you do that, actually right, entering the dorsal mapping with the right side as well as the left side, you can see that actually right stimulation, you can see the C3, C4 dash, you are getting a very good response from the P20 and N20 and P25. And left side, when you're stimulating, you can see the same, which is the N20 and P25, which is in the left side, which is the reverse in the polarity. And the midline, you can see that where you can highly safe zone to enter into the reach the tumor for the resection. And coming to the warning, that SSCP is that 50% amplitude protection as well as a 10% production in latency. That is a global standard of the care for the warning criteria. Since the intermediate tumor or extramedullary tumors, which is performed dorsally most of the time, the damage to sensory path is more probable, which causes the changes in signals. Tumors with a location may also differ with the SSCP sensitivity, which is tumor in the thoracic are higher specifics and specificity with the SSCPs than the lumbar level. Coming to there are some limitations with the SSCPs are this requires averaging, prolongs the acquisition of results and delays in interpretation. This might increase the risk of neurological damage that causes SSCP models of only the sensory pathways, injury to motor pathways still will not be detected. And also, more false negative results are more probable with the SSCPs. Coming to the another technique, which is the motor potentials, this can be done by stimulating the transcranial electrically as well as magnetically and recording the response from the skeletal muscles through the needle electrode or sticky electrode, patch electrodes. In coming to the transcranial stimulation, there are two different stimulation devices which is there. One is the traditional constant current stimulation, which requires a slow charge, which is necessary for the 50 microseconds pulse duration. The maximum current we can deliver to 250 milliamp. The another traditional constant voltage stimulation, which is a widely used overall and which requires 50 to 75 microseconds pulse duration, which is a fast charge, which is really sufficient to elicit the targeted muscle response from the MEPs, compound muscle action potential. Coming to this transcranial stimulation, the stimulation circuits is very important. Non-optimal position of the stimulation circuits, which gives the false negative information. In traditionally, let's go for the cortical size, which is C1, C2, C3, C4, and CZ plus 6 centimeter, which is the cortical side for the traditional stimulation side. Now, the other side is actually motor side, which comes as a new phenomenon called M1, M2, M3, M4, and MZ. In this case, actually, identifying the optimal stimulation circuit based on the clinical conditions and to assess the motor tracks and appropriate circuit for the type of surgery and decussation, basically the intradural or extradural and intramedullary, and reliable steady responses and less or no body movements and no bite injury risk. So according to these factors that you need to choose that which stimulation circuit which is suitable for the particular type of surgery. Coming to this M1, M1 and M2, M3, M4, which is 1 centimeter front to the C1, C2 region over here. This is the stimulation montage where we are stimulating the transcranially, and this chooses the current direction which is going through the longitudinal and parallel to the most of the permanent tract fibers, which elicits a very strong, robust compound muscle action potential from the muscles. This is a typical illustrative example of that motor potential where the stimulation side and recording the muscles. And when we come to that, actually, we have two different medial interhemispheric stimulation site, which causes from M1 to M2. It can be used for both brain as well as spine surgery, but however, in the condition of spine, it very more focal to the lower limb monitoring. When we come to the lateral interhemispheric stimulation, the transcranial stimulation, which goes the montage generate a centrally distributed high electric field. The current direction is longitudinal and parallel to the permanent tract fibers. This is the most effective site of MEP stimulation. May not be directly the superficial. It goes and activates deep sulci that causes more effective to get the clear signals from the cortical spinal tracts. And also, this requires the less threshold for both upper limb as well as lower limb. You can see that for the medial interhemispheric stimulation, you can get the response only from the highest threshold from the lower limb than the upper limb. When it comes to lateral interhemispheric, you are getting both upper limb as well as lower limb muscles. What we're doing in our center is actually this is a lateral interhemispheric stimulation with the biphasic stimulation method, which gives the very high and robust responses from the corticospinal tract to the targeted muscle target. In this case, identifying the optimal stimulation circuit based on the clinical condition, which is more important to know that motor decussation and maximize the motor cortex monitorability and also the patient safety. This is the stimulation parameter which we use for that stimulation point M3, M4 or NZ, FPZ for the lower limb, and number of pulses is 5 to 8. Frequencies of the stimulation is 3 milliseconds, which is 333 hertz. The recording muscles are flexor corporadialis, bilateral, pollicis brevis, quadriceps, tibialis anterior, soleus, external sphincter, and articular hallucis. This is a typical illustrative example of our recordings. And coming to the illustrative example of that amplitude deterioration with that transcranial stimulation, actually you can see that actually right tibialis anterior and left tibialis anterior. This is the illustrative example of that thoracic intramedullary tumor, which is in the T4 to T6 level. And we can see that laminectomy, we got a very good response from that satisfactory response. But after the dural opening, stop the tumor resection, the amplitude is gradually decreasing from the baseline, and it goes up to the right side is more than 60% from the baseline, and here it goes more than 45% from the baseline, which causes the postoperative one muscle grade deterioration for the patient. Another technique for the spinal tumor is actually direct wave monitoring, which is elicited by the stimulation of the critical number of cortical fibers, cortical spinal tract fibers in the spinal cord. This D wave, which represents synchronous activity of the fast conducting fibers that are activated either distally or near the cell bodies of the pyramidal neurons. These fast conducting fibers of the large pyramidal cells with no synapse arrangements at the end of the terminals, so it is not affected by any anesthetic regimens, so it can easily monitor through the single pulse. This is the technical details which we stimulate at M3 or M4. Number of pulses is 1 with a continuous stimulation, and we use the stimulation strength of 100 to 500 volts continuously. This is a recording electrode, which is a typical spinal catheter electrode, which we can place it one more in the proximal and one more in the distal. Try to record the response from the rostral as well as caudal wave. This is a typical example. You can see that actually rostral, we can get that. Since this is the very minimal potentials, actually the response are very minimal and also very short latency potentials. This is a rostral and caudal responses. Actually, you can see here, and when it comes to this rostral is works as a negative control and caudal is a positive control. If there is a reduction in amplitude or loss of signal, we can identify the tract which is damaged. This is the typical responses which we can see here. Here, this is a caudal, this is a rostral one, and this is a caudal one. And we can see that the response which is coming down with the D wave response with the D4 to D5 response. And this is the another one is the typical illustrative response of the D wave, which we are recording from the cervical level, which is from the 2.3 millisecond with the short latency responses. Here, sometimes along with the D wave, which is the motor wave, we can see the I wave also, which is highly sensitive to the anesthesia agents, not as like a D wave. You can see the stack response over the D wave and I wave here. And we have one case scenario, which is a C1 to C3 intramedullary tumor with a clinical history of 17-year male and pain with the upper back radiating to the right upper limb since 4 months, and no complaint of difficulty in walking since 5 days. And the power is upper and lower limb is the left side is 4/5 and right is 4/5, and bilateral hand grip weakness is there. And the MRI shows that C1 to C3 heterogeneity hyperintelligence component with the heterogeneous constant enhancement with the cord. Edema from the cervicomedullary junction to C3. We impressed that the low-grade glial tumor favorite to the pilocytic astrocytoma or ependymoma. This is a DT image which you can show that there is a predominant displacement of the fiber tracts with the tumor. What we did is actually we have used the intraoperative neuromonitoring with the transcranial MEPs, DVA recording, and SLCPs. In the intraoperative findings, tumor is actually grayish, suckable, moderately vascular. The plates are well defined. When it comes to the D wave, at the lower end, the tumor was densely adherent to the cord, where 100%, 10% loss in the D wave was noticed the initial, And there was a 40% loss in the D wave by the end of the excision, with a recovery back to up to 30% loss. The transcranial MEPs, which can show completely lost on the left side with a 50% loss on the right side. The SSCP is a 50% loss when we are making the dorsal myelotomy, and we achieve the gross total excision. This is the intra picture of the excision one. And you can see that transcranial MEPs with the baseline, which we can get the both bilaterally, we are getting the response on the upper limb as well as lower limb. But into the tumor section, we completely lost on the left side, and right side also upper limb, we lost with more than 70%. When it comes to the D wave response, this is the laminectomy at the stage, the baseline. And when it comes to the middle of the tumor resection, actually 50% tumor resected with a 20% wave, which is deteriorated amplitude, and 70% at 70%, that is a 30% deterioration. And coming to the end of the resection, it's more or less 38% deterioration is there, and the rest of the signals are preserved. This is a post-op image with the sagittal and axial and post-sagittal with that resection cavity. And the final histopathology report comes as a grade 2 epidymoma. Coming to the post-op recovery, the power immediate post-op is deteriorated by 1 grade in the both upper limb as well as lower limb in the left side, and joint position sensation affected in the right lower limb and normal in the left side. After 3 days of post-op, the power is gained back to the normal, to the baseline, and the ambulatory is and can walk with a support. And we need to take an intraoperative decision, and with a D wave is, if the D wave is normal, MEPs are normal, complete surgery as planned, and good post-operative outcome you can achieve. And if the D wave is normal or drops less than 50% from the baseline, MEPs drops more than 50% from the baseline, and corrective measures you can take, like wait for the waveforms to improve and give the saline irrigation and increase the blood pressure, and complete the surgery as planned, and you can get a good post-operative outcome without deficit. When it comes to the other way, the D wave is normal or drops less than 50% baseline, but however, the MEP, transcranial MEPs are drops more than 80% or loss, complete loss. You can take again the corrective measures and wait for the waveforms to recover and proceed for the surgery. In this condition, you may see the postoperative transient weakness since it is more than 80% loss and less than 50% the D wave loss. But when it comes to the corrective measures take, is the general rule that one can proceed the surgery even if the MEPs are lost. However, individual surgeon has to take a decision based on the surgical procedure, pathology. When it comes to another way, the D wave drops more than 50% from the baseline, MEP drops by more than 80% or complete loss. You can take a corrective measure and wait for that waveforms to recover, stop if there is no recovery of the D wave by more than 50%, and post-operative you can find out the permanent weakness. There is another one, lost is actually the D wave unmonitorable. If you cannot able to monitor the D wave and MEP is complete loss, and corrective measures can be taken and wait for the waveforms to recover, and if there is no recovery, stops. But in this condition, either post-operatively, either transient or permanent weakness, you may observe that. When it comes to D wave, this is an excellent neurophysiological marker in supratentive tumor surgery. However, amplitudes tend to be very small compared to the muscle MEPs, and
Dr. Parthiban,
the neurophysiology.
1 minute.
Yeah.
Okay.
Sorry.
1 minute.
Yeah. Neurophysiology must have advanced understanding of the signal-to-noise ratio with an ability to troubleshoot the noise artifact and easing the noise artifact, adjusting the filter settings, stimulating the average correction, and placement of the epidural electrodes in the subdural compartment. This is, you can see that actually signal-to-noise ratio, you can see that the signal-to-noise ratio, one electrode, it can pick up the very less than 1% signal-to-noise ratio, but another one is getting that more than 1 signal-to-noise ratio. That means you need to correct it properly, position appropriately. And coming to the D wave advantages, that the D wave provides a durable and effective metric access to the cortical tract integrity, and it can also serve as a prognostic marker for long-term recovery of the postoperative motor function. However, there are some limitations. The tumor below T10, T11, you cannot able to monitor the D wave, and D wave cortical spinal tract will be affected by electrode placement, like a revision of surgery, mass effect, dense dural adhesions, and also it cannot be detected laterality of the weakness. Coming to the another one is the nerve root monitoring, which is a pre-run EMG, which is the useful for the choroid mass and intraocular monitor nerve root with the spontaneous activity. It can tell you the two discharges, neurotonic and myotonic, and you can see that neurotonic discharges, which comes repetitive steady state burst, and the myotonic discharges is the little synchronous burst of motor interactivity. You can see that myotonic discharge over here. And the another one is the triggered EMG, which is a nerve root monitoring, which is the direct nerve stimulation. You can use the handheld monopolar or bipolar stimulator, and this gives the appropriate muscles of interest of response. And you can see that actually we use a concentric bipolar. We can see the stimulation induced sphincter muscles activity over here. And for this warning criteria for that, this nerve root indicator triggered EMG actually irregular periodic burst repeatedly and prolonged for more than 3 seconds, and an acute drop in signal for more than 1 hour more late. The pre-running EMG is a sensitivity of more than 85%, 87% and 83% specificity. The possibility is 87%, negativity is 83%. Coming to the last one is the bulbar cavernous reflex, which is a very important reflex for the somatic polysymptomatic, which is cervical level, sacral level, S2 to S4. This PCR helps to distinguish the upper motor neuron lesions from the lower motor lesion, which is important for the bowel and bladder function. And the stimulation of the is basically the dorsal penile or the clitoral nerves with the surface electrode, and recording from the external sphincter muscles. The stimulation parameters are short range of 4 to 5 pulses. Current strength is 10 to 25 millia. This is a typical waveforms where we are recording that the bulbar cavernous reflex bilaterally over here. And this is another video which we can record the bulbar cavernous reflex bilaterally from the muscles. The warning criteria for the BCR is no alert criteria so far exist in the literature as well as our response actually correct. However, the disappearance of the response is considered as a alarm in the current setting. That intraoperative BCR data and the correlation is highly important for the long-term sphincter control, sphincter dyssynergia, and sexual functions. In overall, coming to the multimodality with the setup with the spinal tumors, the extradural, these are the setups you can use for. These are the modalities of pre-run EMG is optional for extradural, and triggered is optional. SSCP is not applicable. MEP is mandatory. D-wave is not applicable. Reflex. When it comes to the intradural, the mandatory optional for the pre-run triggered EMG, and intramedullary for the it's a mandatory pre-run EMG, and triggered is optional, but SSCP, MEPs, and D-wave is mandatory. And reflex monitoring is mandatory below cervical level, whatever the conditions. And conus lesion, this all the monitors are mandatory pre-run triggered EMG, and but D-wave is not applicable. SSCP is optional, but MEP is mandatory, and reflex is highly mandatory. Coming to the conclusion, spinal tumor surgery carries a risk of new neurological deficits. Single monitor techniques not suffice for the monitoring the entire spinal cord functions. Multimodal technique is essential for monitoring to prevent the new neurological deficits, and multimodal INM gives a highly sensitive and specific for anticipating neurological injury. It represents an important tool in preserving neurostructures and achieving the optimal postoperative functional outcomes in spinal tumors. My sincere thanks to my surgical team and my technical team and the students. And we'd like to invite all you for the coming International Certified Top Surgery, which we are hosting in 2026 in Mumbai, India, in November. Thank you all.
Thank you, Dr. Parthiban.